Assalamu alaikum. On behalf of PSA Karachi, I welcome all of you in the lecture series. Today, we have a very seasoned anesthetist, an intensivist, and a very good administrator, Dr. Farjad Sultan, with us. Let me take the privilege to introduce him. He did his graduation from Dow Medical College, and after completing his internship at Civil Hospital Karachi, he proceeded for higher education and training to UK and Ireland. He cleared his final fellowship in 2008 from the Royal College of Anesthesia, Ireland. Then he proceeded for a fellowship in regional anesthesia from Cork University Hospital. He was awarded CCST in 2013 and is on the specialist registrar. He also has a fellowship in critical care from the College of Anaesthetists Ireland and a PhD in training in the assessment of procedural skills required for ultrasound guided peripheral nerve blockade. From National University Ireland, University College Cork awarded in 2016. He then returned to Karachi, Pakistan in 2013 and joined the Indus Hospital as the head of critical care, where he helped develop the critical care network. Dr. Farjad, looking for a further challenge, joined the Department of Anesthesia at Dow University of Health Sciences in 2019. He was instrumental in the planning and implementation of COVID ICU at Civil Hospital Karachi and was also responsible for planning and running of the standalone COVID ICU HDU at the Expo Center for 2 years as a volunteer and treating near 4,000 organ failure COVID patients with his team. He is presently the chairperson of anesthesia at Dow University of Health Sciences and is also the director of the Professional Development Center at the Dow University Health Sciences, being responsible for managing of the undergraduate skill lab, American Heart Association activity monitoring of Pakistan, Asir Rahman Simulation Center, and the CME section at Dow University Health Sciences with his team. He had represented the DUHS at multiple international conferences as a speaker and at national conferences as a keynote speaker. He's a master trainer for a number of international ICU and trauma courses, as well as a trainer in all anesthesia and ICU related national conferences in Pakistan. So we welcome Dr. Farjad Sultan. The topic which he will discuss with us is the central line associated bloodstream infection and care bundle. It is a very important topic, and I think every person who belongs to anesthesia and ICU should know about this in detail. Meanwhile, I will request all the participants to please keep their cell phone on the silent mode. And if they have any question, they can write it down in the chat box. Dr. Farjad, please take the mic.
Thank you very much, Dr. Azhar. Very kind of you for such a introduction. First of all, thank you for the organizers for giving me this opportunity. So I hope everybody can see my screen and it's visible to all.
Yeah,
Thank you. Thank you. So I've been asked to present something about central line associated bloodstream infection and care bundles. And so we'll go through what central line associated blood infections are, and what care bundles are and why they are a bit important and how they were formed. So what's the impact of CLABSI? So 90% of catheter-related bloodstream infections are associated with central lines. So if you look at the data, so there are nearly 250,000 of CLABSI annually in the US. 80,000 cases occur annually in ICUs. And the mortality of CLABSI is 12 to 25%. And the cost goes from $20,000 to $56,000 per episode of CLABSI that happens. So that's a huge impact on any health sector. Oh, sorry, there we go. So what are the contamination sources? Well, it starts with the hand of the medical personnel. There's hub colonization. There's extraluminal, which migrate across, which is around 70%, intraluminal, which is quite rare. And we have to consider in mind, and we have to consider that the patient's skin have a microflora present, and they are also can be the source of contamination on insertion and may cause hematogenous spread. The sources of microorganisms starts with touch contamination on the inner aspect of the catheter. The catheter hub, that is the main source that it is. The number of times you go into ICU and you can see where different hubs are uncapped, one, or they are opened up without proper sterilization techniques or clean hands, and something is given and then it's capped again. So even that thing, it's routine care, people do it all the time, but that is another huge source. The second is the skin entry or exit site. The skin, which is, and this is on the outer aspect of the catheter, where which can go in, and what it does is, so this is the skin flora that we're talking about. And what it does is it goes along the catheter, and once it's there, it enters the bloodstream. Or the third aspect can be hematogenous spread from a distant site. So infection sources somewhere else, it comes in, and we have to remember that this is not a natural piece of, or not a natural organ. It's a catheter, and it is, and it does not function as a normal organ where the hematogenous spread may not occur. So the bacteria may come and get anchored onto the central line, starting from the tip outside or inside and causing a biofilm. So the evidence-based strategies to prevent CLABSI revolve around 5 best practices. And when these practices are bundled together, that's where we call a care bundle. And these practices start with, one, good hand hygiene. Second is the use of maximal barrier precaution for insertion. Third is the use of chlorhexidine or alcohol to prepare the skin. Fourth is site selection for catheter and avoidance of femoral vein for central venous access in adult patients. And the fifth is the daily review of lines necessity for, or prompt removal of unnecessary lines. You don't need it, take it out. So hand hygiene and what we need to know. So there have been more than 20 studies, including more than 8 prospective studies, where improvement of hand hygiene compliance significantly decreases nosocomial infection rates. We all know, we all work in hospitals, and we all have seen the hand hygiene signs. They are up there for a reason. We should use it more. And the barrier protection and hand hygiene has become more and more important after COVID. And we have to realize that if we do not do proper hand hygiene, not only are we cross-contaminating between the patients, but we are taking these hospital bugs who are highly resistant, who are quite toxic and quite dangerous, and we're taking them home with us and exposing the world and our family to these things. So hand hygiene is very important before, during, and after patient interaction. Alcohol hand rubs are efficacious and easier to use than soap and water, saves a bit of time and a lot of water as well. And it is the first important step in preventing CLABSI. Regarding maximal barrier protection, it is suggested that a large drape covers the whole patient, not just the area where we're performing, but there's a complete from head to toe. It is very important because we don't know when we might need to move or put a piece of equipment. If you have a small area, sterile and only covered, you are asking for disaster because you will be contaminating your own sterile self as well. So you have to keep these things in mind. The maximum barrier protections are for the operator and supervisor. So hand hygiene, non-sterile cap and mask, all hair should be covered and under a cap. These includes beards and mustaches as well. A lot of people will say, specifically surgeons, that it is not important. I'm sorry, but it is important when putting in central lines. Mask should cover the nose and mouth tightly. And we have seen the cross-contamination with improper fitting of mask during the COVID period. So we all realize how it can cross-contaminate between the operator, patient, or the assistants. sterile gown and sterile gloves as well. For the patient from head to toe with a single large sterile drape preferably. For the assistant who is there not touching the patient, but assisting with prep and drape and with the procedure, hand hygiene, non-sterile cap and mask. Again, all the hair should be under the cap, including the beard and mustache. The mask should cover the nose and mouth tightly, sterile gloves and sterile gown. People who are in the same room but not involved in the procedure or who are not at risk for crossing the sterile field do not need to wear maximum barrier precautions. But those who are observer and coming in and peeking should at least have a cap and a mask. And they should be very aware that they are not touching or causing contamination with the sterile field. Regarding chlorhexidine and alcohol skin prep, it is recommended that it is better than povidone iodine or betadine. There have been meta-analysis which have said that it's a lot better. It found that the use of chlorhexidine reduced the CLABSI rate by 49%. That's half of the 250,000 that occurred. So that's cut down by half, and that has a huge healthcare impact in all aspects. So usually we prep the skin by a chlorhexidine 2% in 70% isopropyl alcohol. The picture you see on the top right corner, that's the classical chlor prep applicator. You pop the ampule, you saturate the pad, press the sponge against the skin, apply the solution using a back and forth friction rub for at least 30 seconds. After that, you let it dry. You do not wipe it off. You do not blot it off. You let it dry completely before puncturing the site. If it takes a minute, 2 minutes, 3 minutes, that's perfectly fine. But you let it dry where they've waited for hours or minutes. 2 minutes will not make that much of a difference, siting it in, but it will make a difference with the survival rate and complication rate of the patient. What about the choice of site? Everywhere it has well documented in adults, the femoral site should be avoided. But where's the data of it? In a clinical trial of ICU patients who were randomized to femoral or subclavian lines, there was a higher rate of infectious complication in the femoral group. There was a higher rate of thrombotic complication in femoral group. But this is quite old data, but it is so convincing that one does not need to redo the research to do it. Why should we put a patient to increased risk? We know that a femoral site is a suboptimal site for siting in central lines unless you're really stuck. So the preferred order preference is subclavian as the first choice, internal jugular is the second, and if you on the right and left, if you have nothing else, you go for the femoral. Using of a two-dimensional ultrasound is now standard of care, and this includes having a proper sterile cover for all. As you can see, the complete barrier protection by the operator, and you can see very clearly that the ultrasound probe has a sterile dressing and a sterile cover on it. So ultrasound guided versus anatomical landmarks. So meta-analysis of 18 RCTs. How was ultrasound better? Well, use of ultrasound had a relative risk reduction of 86% for failed placement, relative risk reduction of 57% for complications, relative risk reduction of 41% for first attempt failures, relative risk reduction of 1.5 attempts, and time for those experienced practitioner, 69.3 seconds, and the central line was in place and checked and ready for use. So it does save a lot, and we should all be trained in ultrasound guided techniques. We should know the landmarks as well, but using of ultrasound is now standard of care, and if putting in central lines in a control setting, it should be used. The special consideration for site selection is also very important to consider. Some of the factors which may have an effect on site selection is anatomic deformities. any presence of coagulopathy. So use a compressible site, an IJ, and not the subclavian. For hemodialysis patients, the National Kidney Foundation guidelines recommended against the use of subclavian vein for any central line unless use of the IJ vein is absolutely contraindicated. And what they did say was that it was due to the risk of subclavian vein stenosis, which may cause an obstruction to flow for dialysis patients and when they make a fistula for dialysis, and these fistulas don't work as well, and they run to a lot of complications. For dialysis line, subclavian should be avoided. If internal jugular is chosen, to use the right side to reduce the risk of mechanical complication, because we have to remember that if you put it on the left side, it has to go across to enter the heart as well. So it is a bit tedious and quite and I won't say complicated, but it can cause a complication, mechanical complication. What about post-insertion care? Antimicrobial ointments do not reduce the incidence of CLABSI except in hemodialysis catheters. So routine use is not recommended. Application of sterile dressing at the insertion site before the sterile drapes are removed is very, very important. So you don't take the drapes off first. We have seen it and we have made this mistake. I think all of us have, that we take the drapes off and then we put the dressing on, which is wrong. We should develop a habit of put the dressing on and then remove the drapes. Transparent dressings are preferred to allow the visualization of the site. Why? Because if there's redness of site, you can view it. If you can't see the site, you don't know how dirty or clean the site is. If the insertion site is oozing, apply a gauze dressing instead of a transparent dressing and replace the dressings once the dressing become damp, loosened, soiled, or after lifting the dressing to inspect the site. So you lift the dressing, change it rather than sticking it back on, because then you have caused a bit of contamination. Evaluate the medical necessity of IV catheters daily with the patient care team. Do the care team understand and communicate the reason for the stent line? Is it actually required? If it is not required, we should remove the central line catheter as early as possible. So there has to be a need for it. We should justify why we are putting in a catheter, central line, and why we are retaining it. So in summary, the prevention of CLABSI is the indication. Do we actually need it? If we don't need it, don't put it in. Which is the site? Prefer other sites from femoral, but if you really have to, you have to. Skin preparation is very important. Use chlorhexidine or alcohol. It is better than pyridine. I won't say do not use pyridine, because in some places they may only have pyridine, but again, you have to apply it for at least 30 seconds and you have to let it dry. Whether it's chlorhexidine or pyridine or hexidine, whichever it is that you use, please let it dry. It will take a few minutes, but it does improve the complication rate. Compliance with best practice, hand hygiene, maximum barriers, the correct reason for line continuation. Do you require it now? This is something that should be shared, that should be considered and thought of every time that you're doing a round or looking at the patient, at least every day, if not with every shift change. And the communication with team to assure compliance to all of the above. So continuous monitoring and audit process to see if these things are happening. I do realize in a lot of places, we do have problems with availability of appropriate equipment, but we should try our best to follow the good practice guidelines. Now, moving on to care bundles, I'll take all the questions and queries at the very end, if that's okay with everybody. So what we're going to do is we're going to discuss what are care bundles, what are the background of care bundles, and the type of care bundles which are already available. So we all should aim towards standards of care. we are committed to delivering high standard of care to all patients. Some patients are not better than others. For us, they're all the same. Standards of care are generally defined by evidence-based guidelines, such as infection control guidelines, and we have different countries have actually different processes. Some have SARI guidelines, there are CDC guidelines in the USA, and the EPIC or NICE guidelines in the UK, and they are there to give a standard of care that this is the thing that should be done to all patients, and the reason is that it will improve the outcome of the patient. So what is a care bundle? Care bundle is a collection of interventions, usually 3 to 5, and these are evidence-based. Once a combination of these care bundles will improve, a combination of these interventions will improve patient outcomes. So using one intervention improves it, using two interventions may improve it, but using 3 or 5, all of which are improving outcomes combined together, that forms a care bundle. All clinical staff know that these interventions are best practice, and they make it as a part of routine care. Care bundle is a means to ensure that everyone is consistent with what they do to all patients at all times, hence improving the outcomes for all. So what's the background of care bundles? The first care bundle was for the insertion and management of central venous catheters by Dr. Peter Pronovost. He's an intensivist in Michigan, and he developed a checklist for insertion and management of central venous catheters to ensure that the key interventions recommended by the CDC 2002 guidelines were implemented every time a CVC was inserted. And these interventions, we've just gone through it, but these were the 5 things that he did. And this is, so these were individual interventions in 2002 guidelines by the CDC. He just combined it all together. So hand decontamination pre-insertion, full sterile barrier precautions for the operator and the patient, 2% chlorhexidine for skin disinfection, avoiding the femoral site, and unnecessary catheters to be removed. So it's quite common sense. It's not rocket science that you need a large group of very intelligent geniuses to do it. This is common sense. We know what is going to improve patient care. We can form bundles. So what they did was they took data from 103 ITUs in 67 hospitals as a study result, and median rate of catheter-related bloodstream infection per 1,000 catheter days decreased from 2.7 to 0 at 3 months after the implementation of just these 5 interventions. 65% reduction in catheter-related bloodstream infection over the 18 months of study. That is a huge thing. That has huge healthcare implication. And once we start showing the improvement in patient care, the administration and everybody, all the doctors, they will agree to it. So what are the different type of care bundles that we have? Well, let's start with the WHO surgical safety checklist. That too is a care bundle. It has questions, which is quite important. We have the urinary catheter care bundle, the insertion and management, the Clostridium difficile care bundle, the VAP care bundle, palliative care bundle, pressure area care bundle, sepsis care bundle, peripheral vein catheter care bundle. I won't go into the details for all, but I will touch a few of them as we go along. So the WHO surgical safety checklist for safer surgery has been there since 2008 and before. The evidence was reviewed for systems that improve safety of patients, and these were identified, the deficiencies were identified following mishaps such as wrong patient, wrong site, wrong surgery. So that, I mean, if you can imagine a patient coming in for type A surgery and getting a type B surgery, coming in for a removal of gallbladder and getting his kidney taken out, that or coming in for amputation of right leg and getting his left leg chopped off, or a wrong patient getting their legs chopped off. It's a disaster. So the checklist was developed to be used in all theater, irrespective whether it was a first world country or a developing country or a third world country. And it was tested in 8 hospitals across 8 countries. And what it showed was, as compared to the initial data, there was a 36% overall reduction in postoperative complications. This is the surgical safety checklist, which I think nearly all hospitals all over, at least Pakistan, if not all over the world, have implemented. It is quite straightforward. There's a sign in, that is before the patient comes in. There's a timeout when the patient is in theater, and then there's a sign out when the patient is leaving. So if you think on it, it's not rocket science. These are the 3 times when when identification of the patient, the team, the operation, the equipment, it is checked and cross-checked and cross-checked, and it is all there for patient safety. Then we have the WAP bundle, which is a straightforward, simple elevation of the head of the bed to between 30 to 45 degrees, daily sedation breaks, and daily assessment for the readiness to extubate the patient. Why do we need to keep a patient intubated if we don't have to? Peptic ulcer disease prophylaxis and DVT prophylaxis if not contraindicated. So 4 or 5 things combined together form a bundle, and which reduces the incidence of pneumonia. Same with the urinary catheter care bundle, there's insertion and management. So insert only for specific reasons. So urinary output in critical illness, bladder outlet obstruction or neurogenic bladder dysfunction, prevent contamination of sacral or surrounding wounds, and if there's terminal care patient is there. Again, it should be cited by a competent healthcare worker using aseptic technique, and a closed system with bag below the level of the bladder should be used. Regarding management, there's a review of need of catheter daily, empty when it is 3/4 full, and use a clean container for each patient. You shouldn't empty in 1, 2, 3, 4, 5. So there is cross-contamination risk over here as well. Secure it to the leg or the abdomen so it's not going all over the place. The sample should be taken from sampling port only, so avoid the disconnection again and again. Hand hygiene and PP before and after any catheter care. So not only after handling it, but before and after, one should do hand hygiene and discard the used PPEs as well. The sepsis bundle. So in 2004, the European Society of Intensive Care Medicine, the Society of Critical Care Medicine, and the International Sepsis Forum published guidelines for the management of severe sepsis and septic shock. 2 initial care bundles evolved from these guidelines: the severe sepsis research bundle and the severe sepsis management bundle. Now, this is 2004, which is 20 years ago. A lot has happened in the last 20 years regarding sepsis bundles. Not grossly, but micro changes have happened. And the Surviving Sepsis campaign has been there. The international management guidelines for the management of sepsis and septic shock was published in 2021 in the Critical Care Medicine Journal in November. And it is there, it is open access. Talking about Pakistan, we have local guidelines for management of sepsis in adults, the sepsis guidelines of Pakistan. This is there and it has been published as well. And I think this was developed just before COVID. So I think it was 2019 where when this was developed, and it involved a lot of societies. So Pakistan Society of Critical Care Medicine, Pakistan Society of Anesthesiologists, the Medical Microbiology and Infectious Diseases Society of Pakistan, and the Pakistan Chest Society as well, and involvement of a number of senior people and institutions as well. Then we move on to the pressure ulcer prevention bundle. Again, 8 things. So there's risk assessment, the Braden tool, whether the patient is at risk, skin assessment 8-hourly, the head of the bed elevated less than 30 degrees, unless contraindicated or superseded by the WAP bundle. So again, the bundles, one bundle says go above 30, the other bundle says go below 30. So which one is more important? That is a clinical decision. So there are no absolutes. Incontinence skincare, position changes. So if the patient is bedbound, 2-hourly. If they are sitting on a chair, they should be moved hourly as well. The heel elevation, nutrition assessment, and pressure relief mattresses. Again, not a replacement for positional changes. They're two separate things as well. They're two separate entities. The CDF care bundle, so it's very important because CDF is quite it's very difficult to treat, and it is just jumps between patients very easily. So isolate all CDI patients, preferably in a single room with clinical hand washing sink, and ensure ensuite facilities or designated toilet for all the contaminated stuff coming out until they are at least 48 hours symptom free. Review the patient's antibiotic regimen, stop all the inappropriate antibiotics. Check that all healthcare workers remove their PPEs immediately after each contact with the CDI patient and their environment. So this just signifies the importance of realizing how easily C. diff can spread in between patient and go cross-contamination. Ensure that healthcare workers perform hand hygiene with liquid soap and water immediately after removal of PPs. So not just the alcohol one, but once you're out from the CDI patient environment, you take everything off, you take all the PPs off, and you wash with soap and water. Check that the CDI's patient immediate environment and all patient care equipment has been cleaned daily with a neutral detergent and disinfected with sporicidal disinfectants. So you do not want to transfer or have multiple patients of C. diff in ICU. So again, quite common sense is there. There is a patient who has a highly contagious, for want of a better word, disease process, which may cross-contaminate other patients. So you take maximum precautions. The peripheral venous catheter care bundle is there. This has been adopted from the Health Protection Scotland care bundle. The management of PVCs, if you don't put them in. If you don't need them, don't put in a cannula. If you have to put one in, look after them properly. If you don't need it anymore, get them out. These are very quite straightforward and simple. These should be adopted locally. Example, removal after 72 hours. Do not apply to pediatrics for reasons enough that the pediatric population is quite a challenge to cite venous catheters or venous cannulas in. So in summary, a care bundle is a simple tool used to improve reliability in care delivery. The elements must be evidence-based. You can make your own bundles. Doesn't mean that these are absolutes. All of these things are guidelines. If you think you need to add something, you add it, but you must have evidence for it. And it can be used, bundles are quite robust in the sense that they can be used for different conditions or treatment, and they can be adopted locally. You can add things to it, but again, please keep in mind that you should have some evidence base of it. So that's it. Thank you very much for listening to me. And if there are any questions, I'll be more than happy to take them.
Thank you, Dr. Farjad, for giving such an insightful talk. So we have a big name from the world of anesthesia and intensive care. May I request Dr. Fazal Hamid to please comment?
Oh, thank you, Azhar. I think there are some questions as well from the audience, but I must say and want to congratulate the PSA as well as Dr. Farjad Sultan for sharing a very, very excellent talk with us. And basically, I think the important take-home message from this talk, and Farjad has really very nicely, concisely summarized the main things that we should be doing in our ICU, some small things, simple things, care bundles. And I can suggest to those actually trainees or those people who are actually running the ICU to go again for this lecture, the recorded version, and take key actually points from this talk based on the availability of the things in their center. But I'm sure that if they try to actually implement 60% of this talk to their ICU, they will give a huge benefit. And I think Farjad deserves all the like praise for this concising such a big and vast topic in such a short time and in such a nice way. Thank you, Farjad, for this excellent talk.
Thank you very
Thank you,
much, sir.
sir.
You are too kind. Thank you.
So we have a couple of questions. First question is by Dr. Hagdad Durrani. They want to ask, previously we traditionally use a subclavian vein catheterization. Later, internal jugular was preferred. Now, subclavian is again preferred. Any recommendation for supraclavicular approach of subclavian vein catheterization, landmark versus the ultrasound guided? Any comment?
So, subclavian vein is still preferred. One of the reasons that the IJ was preferred previously was a lot of the patients, we don't, specifically those coming in emergencies, we don't know what the coagulation status are or if they're bleeding. So the IJ is a compressible vein, whereas the subclavian isn't. Secondly, a number of patients, there was a huge risk in between, which the Kidney Association or Kidney Foundation have quite stressed upon, is the subclavian vein stenosis, which later on they had problems in running the dialysis fistulas. Regarding supraclavicular approach, I haven't used it. I'm not sure. I mean, if I have ultrasound, I'll put it in the IJ. So I honestly don't know the subclavian. The use of ultrasound for subclavian is quite awkward, and it's quite difficult. It has been used, but it's easier for the subclavian with the landmark technique. That's what I have. I'll be more than happy to see what Dr. Hagdad Durrani's experience is. I can see he has a publication in it, so I'm pretty sure I'll open it up and have a look at it. Sir, thank you.
Yeah. So there is another question by Dr. Hafizullah. They want to ask, can you explain the role of antimicrobial coated catheter in preventing infection and their effectiveness compared to standard catheters?
So thank you for the question. That is a very nice question. I was hoping someone was going to ask the importance of the antibiotic-coated catheters. So if you are putting in a central line for a short period or very specific, and you know that it is only there for monitoring and we may not need to extend it, I would use a standard catheter. The antibiotic-coated or the coated catheters are there for long-term use. The evidence suggests that they have a reduced incidence of epilepsy, but you have to keep in mind that just because antibiotic coated does not mean that you can get rid of the bundle. This is on the precedent that the bundle is followed throughout. So you do everything, and then this is an add-on to the bundle. So it does not replace the bundle in any way. So the site selection, the hand hygiene, the protectiveness, and using full complete barrier techniques, the use of ultrasound, the dressing. So the catheter itself, just because it is coated, and there's literature saying, evidence saying that it reduces the infection, does not mean we can put it in without washing our hands. So the first thing, the care bundle does not go away. This is a separate issue, not related to the care bundle, but just the incidence of CLABSI. So if you're expecting it to stay in long-term in septic patients, there is evidence that it does cause a reduction in the incidence of CLABSI. I hope that answers the question.
Yeah, it was nicely answered. So we have another couple of questions. Do we have any local guideline? Yes, you have already mentioned a local guideline. Is it applicable in low resource countries, ICUs as well? And we don't have chlorhex in our setup. What solution should we use as an antiseptic solution? And is there any significance of contact time of that solution as well?
So the local guidelines, so all these care bundles, when they were developed, they are quite straightforward and simple. And I think Dr. Fazal Hamid has said it quite rightly that if you put your mind to it, you can achieve more than 60% of the things that we do. They are achievable. It may take a bit of time, but these things are doable. We are a resource limited setting. So for limited setting, keeping that in mind, the sepsis guidelines for Pakistan were developed in 2019. They are freely available on the net as well. So please access them. So yes, all these things are applicable to developing countries and our country as well. What was the other part of the question? Sorry, I didn't get the other part.
Yeah, alternative solution that don't have chlorhex with them and
Right.
contact time as well.
So I did mention the talk that if we do not have chlorhex, we do use pyridine, but again, let it dry. So I think the recommendation for pyridine is that you should clean for 30, it's the same as chlorhexidine, clean it for 30 seconds and then let it dry, even if it may take 2 or 3 minutes. So is the change of the chemical, but not the contact time and not the concept. If the pyridine is dry, we don't dab it off. We need to wait a few minutes. We just need to be a bit patient. If you don't have chlorhexidine, we can use pyridine as well. So that's not a problem at all.
Thank you. So I will request to all the participants to please fill in the feedback form to get the certificate, and link is already shared. We don't have any other question. Meanwhile, we have Dr. Shabbir Jumani, ex-president, PSA Karachi, with us. I will request him to please give the concluding remarks.
I was about to type a message for Dr. Farjad Sultan. It's a very well researched and very well presented lecture. Wonderful, Dr. Farjad. Congratulations.
Thank you, sir.
Thank you. So that's all for today. Very nicely presented, and all the questions are answered very well. Thank you to all the participants and our speaker, Dr. Farjad, Dr. Fazal, for being with us, and Dr. Shabir Jumani. Thank you. Thanks a lot. We'll see you again.
Thank you very much, Azhar, and thank you for coordinating and all this. Wouldn't have been able to do it without you. Thank you.
Thank you.